This is part 3, antenatal screening. Today we present the morphology scan with a focus on major fetal malformations. Today is a special day because Zen Master Jimmy celebrated his 12th birthday, and so he is happy to wait for a little while before we start giving him some extra treats. As you know, we presented already part 1 and part 2, and this is the topic of the video today, the morphology scan and a focus on major fetal malformations. For the medical students, this is merely an illustration of a few major congenital malformations as sometimes can be found when we offer routinely a morphology scan or an anatomy ultrasound scan to pregnant women. This is part of screening. Detailed knowledge is not yet required for your exam. Check your local curriculum and your examination guide. So have a look and listen, and don't get too despaired. Just to give you an idea. For junior doctors, I think more insight is required. The morphology scan is offered between 18 and 23 weeks. Earlier if the lady has a normal BMI, and slightly later if the lady is obese. And the major topic is, of course, looking for major structural congenital malformations in the fetus. Here you see an overview what we should be looking at when, according to the Fetal Medicine Foundation in London. And you see, for instance, we look systematically at the head, at the face, at the nasal bone, the four-chamber view of the heart. Outflow tract of the heart, we look at the abdomen, we look at the kidneys, the umbilicus, the bladder, the femur, leg and feet and arms and hand, finding out whether the hand is open or closed, because a clenched hand is associated with trisomy 18. And we get views of the spine. And of course we look at the placenta and the cervix and the amniotic fluid. So I can understand if this is your response to this quite busy slide. Please stop overwhelming me. Okay. When we do the morphology scan, apart from looking at the structure, at the anatomy, we also do 3 more things. One is the fetal biometry is measured, the head circumference, the biparietal diameter, the abdominal circumference, and the femur length. And the report will mention on what percentile the biometry is located. So if the biometry would be less than the 10th centile, less than the P10, of course the first question we have to answer, are the dates correct? For that I refer you to the dedicated DAROGA video. The second option could be, of course, that we're dealing with a very early intrauterine growth restriction, IUGR, and then we have to focus on the fetus. Is there signs and symptoms of congenital infectious diseases such as toxoplasma or cytomegalovirus? The second item is, of course, the location of the placenta, and the third one, that the sonographers and the radiologists will report the amount of amniotic fluid. So let's go back to the number 1 item, that's why it's called morphology scan. Let's look at some major congenital malformations. This is by no means a complete overview. I just would like you to show you a few examples of a few tracks as an illustration. The 5 so-called soft markers for aneuploidy are not presented here. Those markers are mild enlargement of the ventricles, cyst in the choroid plexus in the brain, thickened nuchal fold, echogenic bowel, and an echogenic focus in the heart. So these are not presented here. So let's go to the central nervous system. The right panel shows a normal sized ventricles, anterior horn here, the posterior horn there, and this is the choroid plexus normal. And here we see the diameter of the anterior horn, and look, compare that with the diameter in the picture left. It's clear that these ventricles are enlarged and that dangling within is the choroid plexus, which is a vascular structure in principle. So on the right hand side a normal picture and on the left hand side an abnormal picture. In this particular example we will look at also the coexistence of neural tube defect further down. For instance, here are we looking for a spina bifida. The left panel shows a normal vertebral column and nicely clothed skin here in the sacral area. Here we see the buttock of the baby, and on the right hand side we see clearly a cystic structure at the level of the sacrum. The sacrum is protruding slightly, and this raises the suspicion of spina bifida, of course, and the meningocoele. Here we see the different variations depicted systematically. On the left hand side a normal spine. In this panel shows a spina bifida occulta, and here we see the meningocoele and the meningomyelocele, where clearly also the nervous system is protruding in the cyst in the seal. Additionally, we will observe from doing the ultrasound scan whether we can find a functioning bladder or not, and whether the limbs are moving or not, and that gives us an indication of the prognosis. And based on that prognosis we will counsel the parents. In very severe cases that might even be to terminate the pregnancy. Of course, here is it important that we refer the couple to a specialist pediatric neurosurgeon, neurologist, to do a detailed assessment and based on that give them an advice. Here a picture of a normal heart. This is the so-called four-chamber view, and here we see the ventricular walls, thick, nice thick walls, and this is the septum. It's clearly visible that it's intact. On the right hand side now we see the same in a color Doppler. Here in the middle we see the ventricular septum and the blood flow in the ventricles. There is no connection in between. This is a normal picture. That's in contrast with the next one. On the left hand side we see a ventricular septum here, and where the yellow arrow is, it's clearly a septum defect. Color Doppler confirms that beautifully. We see here marked a flow between the ventricles, the right ventricle and left ventricle, confirming a VSD. These VSDs are associated with particularly trisomy 21, and amniocentesis seems to be a logical next step. Of course, we want the cardiologist to perform a fetal echo, a detailed fetal echo of the heart, to look for other cardiac malformations, which sometimes are very hard to visualize. And if need be, a pediatric cardiac thoracic surgeon to counsel the parents, to inform them what to expect after the baby is born. Abdominal wall defects and omphalocoele. This picture is clear that the abdominal wall is not normally closed, but tissue is protruding outside the abdominal wall, and that's apart from a normal umbilical cord. This is a condition associated with many genetic syndromes and especially trisomy, so amniocentesis is the usual next step to check for any abnormalities here, and genetic counseling will take place. Of course, a discussion needs to take place whether this baby can be born a normal vaginal delivery or whether it should be a primary elective caesarean section. Here you see an omphalocoele after the baby is born, and it's covered by peritoneum all the way, and we see here the content is mainly small bowel, so to see. Surgical repair postnatally is warranted by a pediatric surgeon in a specialized center, and of course when the bowel is pushed back into the abdominal cavity, that will give of course also upward movement of the diaphragm and respiratory problems, so this baby needs to be operated in the center where they can deal with these issues with a neonatal intensive care unit where the baby can be ventilated artificially. Another example here is of the limbs. This is an pes equinovarus or a clubfoot. Look at the direction of the feet and it's clear that the baby has normally 5 toes on the left hand side. This is a condition, this is how it looks like postnatally, and the usual treatment is with a brace. So it's important that we offer the parents insight in what to expect after the baby is born, and of course after a while this baby can walk, run and play normally. Another example is the umbilical cord. We see here the top panel showing a 3-vessel cord with 2 arteries and 1 vein. This is the color Doppler, 2 arteries, 1 vein. It's slightly misleading because the arteries carry deoxygenated blood from the fetus to the placenta, while depicted here in red. It's low in oxygen and high in CO2, and in contrast with the vein. So this is completely the other way around of all other arteries and veins you know in the human body. Here we see the picture of cross-section of the umbilical cord with a single umbilical artery or a 2-vessel cord. This is the vein, this is the artery, and this is the macroscopy after the baby is born. What are the consequences of these findings? We look for, of course, for other anomalies, but if no other anomalies are found, and hence it's an isolated finding, the only thing is what we know is that there's increased risk for intrauterine growth restriction. So that means that we will not continue to measure the fundal height as usual, but we will refer to serial ultrasound scan fetal growth, as particularly in the 3rd trimester, so with an interval of 3 weeks roughly. Another example here of a cleft palate. The left hand side we see the grayscale ultrasound scan, also sometimes referred to as the B scan, and the arrow points at this is the lower lip, this is the upper lip, and here we see the defect. This is quite a usual addition is if we perform a 3D ultrasound scan as depicted here. Normal lower lip, and here we see the cleft lip. Of course important to find out whether the palate is involved as well. The management, it's antenatal counseling by the pediatrician, explaining that breastfeeding is usually possible, sometimes with a special some adjustments, and postpartum referral to a dedicated oral maxillofacial surgeon. And sometimes it's useful to meet the surgeon already before the baby is born. In my experience, it's impossible to predict how the parents and the mother will respond to this finding. For some people this is a disaster, especially if it's a baby girl, and for others they are able to put this finding quickly into perspective, and I think we can help them with this. Both responses are okay, it's their unique perception. Here's our task: to share relevant information, refer to an expert if need be, and of course we should never second guess. Acknowledge if you don't know precisely what procedures will take, how many, and at what age. Here, that common denominator of when we break bad news, information and listening are more important than just talking. If a woman would see this picture on the internet, she would be very distressed. But what about giving her this information? This is the same baby girl after procedures, and it looks amazingly normal in my view. So here is giving them reliable information paramount to reduce the stress levels antenatally. This concludes an overview of a few major congenital malformations. The placenta. The location of the placenta. We want to find out whether the placenta is low-lying, and that means does the placenta partly or completely cover the internal os. Please refer to the separate video Placenta Previa, low-lying placenta, where this will be covered in more detail. The other aspect is, of course, that the sonographers will measure the amniotic fluid, and which gives us an idea of the amount of the fluid. We know, of course, that predominantly the amniotic fluid is produced by the fetal kidneys. So, if there is no amniotic fluid whatsoever, an anhydramnios, or also called sometimes severe oligohydramnios, the first thing we have to consider that we are dealing with a bilateral renal malformation or a genesis of both kidneys. Bilateral kystic malformation is one example. The differential diagnosis is, of course, that the lady could also present with preterm, pre-labor rupture of membranes, PPROM. That means that amniotic fluid has been leaking. Usually, a thorough history can tell us whether that's the case or not. The opposite phenomenon is polyhydramnios, when there is more than average amniotic fluid. Here, we think of gastroesophageal fistula, which means the amniotic fluid cannot be swallowed from the mouth into the stomach, or the fetal, that means the fetus has difficulties with or is unable to swallow the amniotic fluid into the stomach. An example of the renal system is here, bilateral renal agenesis. This is the result of absent amniotic fluid, and of notice that the fetus will be almost squashed tightly in the uterus. There is no buffer of amniotic fluid. That means that the fetus has two typical consequences. That's called Potter syndrome, or Potter's sequence. The baby has a typical facial expression and limb contractures, purely a mechanical effect of the absence of amniotic fluid. This is a normal picture of kidneys. The right hand side kidney and the left hand side kidney, and in the middle we see the vertebral column. On the right hand side we see the aorta with the communis, the iliac vessels, and here clearly depicted two renal arteries. This is the physiology. This is normal at 19 weeks. In contrast is here a cross-section through the fetal abdomen, where we are unable to visualize any structures reminding us of kidneys. This is the ultrasound scan Doppler longitudinal section of the aorta and the iliac vessels, and there is nothing which reminds us of the renal arteries. So this raises the suspicion of bilateral congenital agenesis of the kidneys. Of course, we combine that with absence of bladder filling and anhydramnios, and those four are sufficient for the diagnosis. Very confrontational, because the prognosis, of course, means you are unable to live a normal life without kidneys. So usually we offer termination of pregnancy. That appears to be, in this scenario, the lesser of two evils. And of course the parents could choose for expectant management and await the natural course of events, which means that the baby eventually will die postnatally. That concludes the last congenital malformation. Of course, to underpin once more the professional domain for us as doctors working in healthcare, is essential that we identify, manage, discuss and document issues or problems. The documentation is essential. I'll give you two examples. For instance, morphology scan showed bilateral club feet. Pediatricians and orthopedic surgeons are aware. Postnatally, refer to orthopedic surgeon. This is not an emergency, but the baby can be referred a few days after the baby is born. And there's nothing against trying to go for a normal vaginal delivery. Second example is morphology scanned bilateral renal agenesis for termination of pregnancy, mifepristone on the 1st of February, and 2 days later followed by misoprostol. Doctors identify, manage and document issues. That means we perform better as a team. The next person who might see the pregnant lady knows exactly what has been found, what has been discussed and what the management is. That makes your job much easier. Conclusion: we discussed in this third part the morphology ultrasound scan. The morphology, the main reason we do morphology scan is, of course, searching, looking for structural variations in the fetal anatomy, but as well we look at the fetal biometry, at the position of the placenta and the amount of amniotic fluid. Luckily, usually the sky is blue and no abnormalities are detected. But if so, we need to know what precisely is meant, what the possible consequences are for the future of this baby, and of course to whom to refer if need be before we counsel the parents. So first it's good to get detailed information about the abnormalities found. Then the question is where, when and how to deliver the baby in certain circumstances, for instance with a spina bifida or meningomyocele. For the parents and the loved ones, this is without exception very distressful. They fear for the worst. So for us, careful counseling, sharing the information, avoiding to use jargon, empathic explanation, no rush, and counseling are essential part of this. We need to be confident with breaking bad news. We need to be aware of the verbal and non-verbal communication. And let me tell you one thing, if we do this very well, it can be a very meaningful interaction with the parents, because for them it's dark clouds, and sometimes we can help them, providing them the proper information, give them time so they make the decision within the best interest of the baby and themselves in the long term. So this concludes the pregnancy antenatal screening part 3, major congenital fetal malformations. And as promised, here a picture of Jimmy, the birthday boy, and his famous look-alike. In England, English-speaking countries refer to the dog as Snowy. In the French-speaking countries where Tintin originates from, they call him Milou. In Dutch, Bobby. In German, Struppy. Thanks for listening, and I hope you are inspired to look at some more DAROGA videos. Thank you for your attention.